let's talk about some of the other major vessels here. So the subclavian vessels should be familiar to us. We talk about the subclavian vessels when we look at the vasculature of the upper limbs, the upper extremities. So we've got the right subclavian vein being accompanied here with the right subclavian artery. But then we also have the right internal jugular vein, which is draining deoxygenated blood from the head. On the left side, we've got the left subclavian vein running alongside the left subclavian artery. And then we also have the left internal jugular vein bringing blood back from the head. So together, the subclavian vein and the internal jugulars combine to form the brachiocephalic veins. So we talked about the brachiocephalics a bit earlier in this presentation, and we said that they're draining the head, coming from the internal jugular, and the upper extremity coming from the subclavian, and both of those veins drain into the brachiocephalic on either side. And then we also said that the brachiocephalics communicate together to form the superior vena cava, which empties into the right side of the heart. Now, as we can see here, the brachiocephalic vein, now this term innominate is an old term, but it's the same as the brachiocephalic vein, right? So these two terms are interchangeable, this left innominate vein being an older term. And as we can see, the left brachiocephalic vein is longer because it has to communicate across the midline and enter into the superior vena cava, which is on the right side. So here are the corresponding arteries that are kind of being shown separately, but we talked about them already. I do want to point out the carotids. So the arteries won't have a jugular, right? There's no jugular artery. The corresponding artery that's taking blood to the head is called the carotid, and we have the common carotid, which eventually will split off into the external and internal carotid. So whereas in the venous system, we see the subclavian and the jugular forming the brachiocephalic, in the arterial side, we have the carotids and the subclavian, which are branching from the main vessels here. Now, I want to point out that there is no brachiocephalic trunk on the left. So there is only one brachiocephalic trunk. And the right, or the only brachiocephalic trunk, which is found on the right side, will then branch into the right common carotid artery and the right subclavian artery. On the left side, the left common carotid and the left subclavian artery, they come immediately off of the arch of aorta. So there is no brachiocephalic on the left side. These two branches are coming immediately from the arch of aorta. Consequently, these are the three branches that come off of the arch of aorta. We've got the brachiocephalic trunk, which gives rise to the right common carotid and the right subclavian. And then we have the left common carotid and the left subclavian also coming immediately off the arch. So here we can see the branches of the common carotid. So the common carotid is going to supply the head, face, and the scalp. It's going to branch into the internal carotid artery, which goes deep and is supplying the brain. It's going to be a part of the circle of Willis. If you remember the circle of Willis that we talked about from one of our previous units, I think the brain unit last semester, that is coming immediately off of this branch. But then the external branch is going to be running a little bit more superficial. It's going to supply the face and head and scalp with blood coming off of the external branch. I also want to point out the carotid sinus. So the carotid sinus is a structure that you should have talked about in the cardiovascular system in lecture. And this is where we can find the receptors that are involved in the mechanoreceptors, the stretch receptors, the baroreceptors, excuse me, that are found as a part of the cardiovascular system that are detecting the stretch in the wall of this artery and basically responding with parasympathetic or sympathetic responses. All right, we're going to talk about the recurrent laryngeal nerve. This is a branch of the vagus nerve, and it's a really important structure that comes in contact with the heart and the cardiovascular structures, and the main vessels to be specific. So wrapping around the arch of aorta is the left recurrent laryngeal nerve. And so basically we have the vagus nerve. The vagus nerve is a very long nerve. It's one of our cranial nerves. It's coming from the brainstem, from the medulla. It's going to descend. In its descent to the abdomen, it's going to pass through the larynx, it's going to pass through the thorax, and it's going to innervate quite a few structures along the way, namely the larynx. So it's going to innervate quite a few of the laryngeal muscles, as well as uh, autonomic innervation to the lungs and the heart and so on. So one of the main branches that's coming off of the vagus is called the recurrent laryngeal branch. And it's called recurrent because it is going to come off of the vagus, but then it's going to wrap around the aorta and go back up to the larynx, hence the term recurrent laryngeal. And so on the left side, the left recurrent laryngeal wraps around the arch of aorta, but because there is no arch on the right side, the right recurrent laryngeal wraps around the right subclavian artery. This is a really important kind of mismatch with the anatomy that's seen on the left and right side of the heart. So left recurrent laryngeal wraps around the arch of aorta, right recurrent laryngeal wraps around the right subclavian artery. And the importance of the recurrent laryngeal is that we really want to be very careful with any type of cardiothoracic surgery, any type of neck surgery, thyroid surgery, any type of surgery that's happening in this region where that can be affected. This is the nerve that innervates the larynx and is responsible for voice and for the production of sound, which allows us to speak. And so typically we have patients that wake up from surgery and cannot speak, right? And this is because the recurrent laryngeal has been either injured or cut or nicked during the process of any type of cardiothoracic or thyroid surgery. So surgeons are usually very careful about identifying and preserving this nerve and making sure that they're able to distinguish the right side and the left side, especially because they're found in two different areas on right and left. All right, finally, we'll wrap up here and look at the fetal circulation. So I kind of talked about this fetal circulation and the bypassing of the lungs in utero. And I talked about the adult remnant of these two structures. So we talked about the fossa ovalis, which is the adult remnant of the foramen ovalis or foramen ovale. And that is this communication in the right and left atria, in between the right and left atria. So there's typically a hole in the heart. So if you've ever heard a fetus being born with a hole in the heart, this is probably that hole that's being referred to. So during fetal circulation, it is healthy, it is normal to have a hole in the heart, but that should close before or up until the time of birth. And so sometimes it doesn't close, and this is where we have fetuses being born with that hole persisting in the heart. And then the second structure was the ductus arteriosus, which I mentioned is the communication between the pulmonary artery and the arch of aorta, again, in an attempt to bypass the lung circulation or the pulmonary circulation. And so this is called the ductus arteriosus in utero, and then it is going to sort of regress after birth to form the ligamentum arteriosum. So the foramen ovalis becomes the fossa ovalis, and the ductus arteriosus becomes the ligamentum arteriosum, right? And we can see those adult structures here. So when that hole closes, that opening closes, we get just this kind of depression that's felt in the wall of the heart. And in the case of the ductus arteriosus, when that communication closes, we get this ligamentous attachment between the aorta and the pulmonary artery.